Welcome everyone to MedHub Research. I'm Dr. Zach, and it's great to have you with us. Today, we're wrapping up our entire respiratory module with the grand finale, pharmacology. We're going to dive into the drugs that help us all breathe a little easier. Now, if you've been following along with the series, or if you just find this stuff helpful, do me a favor and hit that subscribe button. You really don't want to miss what we have coming up next. All right. Let's get into it. So let's start with this question, because it really gets to the heart of the matter. What happens when your own body, the very system designed to keep you alive, decides to turn on you? In diseases like asthma, that's exactly what's going on. Your airways constrict, they get inflamed, and suddenly every single breath becomes a battle. So how do we fight back pharmacologically? Well, it turns out the battlefield inside our lungs has two major fronts. First, you've got the immediate siege. That's the bronchoconstriction, the sudden, scary tightening of the airways. But then there's the long-term war, and that's the chronic inflammation, the smoldering fire that's always there in the background, just waiting to cause the next attack. Any good treatment plan has to tackle both. Okay, so let's start with that first problem. The immediate siege. When someone can't breathe, we need a drug that acts like a first responder, something that can get in there and open those airways up, and fast. And the undisputed champions here are the beta agonists. You probably know them as rescue inhalers. You can think of these as the emergency door kickers for your airways. They literally bind to receptors on the muscle lining your bronchi and force them to relax and open up. It's what provides that rapid and often life-saving relief. But you know, not all beta agonists are created equal. You've got the short-acting ones, the SABAs, like albuterol. That's your classic rescue inhaler for an acute attack. Then you have the long-acting ones, the LABAs, like salbutamol. These are not for rescue. Think of them as your maintenance crew. They work over a longer period for control and almost always alongside a steroid. Now there's another way to get this done. Instead of forcing the muscle to relax, what if we just block the signal that's telling it to constrict in the first place? Well, that's what muscarinic antagonists, like Ipratropium, do. They work by blocking those parasympathetic nerve pathways, and they're especially useful in conditions like COPD for preventing that airway tightening. So we've opened the airways, we've won the immediate battle. But if we don't do something about that underlying fire, that chronic inflammation, the attacks are just going to keep happening. And that brings us to the long-term strategy. And really, this is the absolute cornerstone of that long-term plan. Inhaled corticosteroids, drugs like fluticasone and budesonide, are the #1 first-line therapy. Now, they won't give you that immediate relief, but they're working behind the scenes, day in and day out, to suppress that inflammation and keep future attacks at bay. So let's take a closer look at what's actually going on. This diagram shows the whole cascade. An allergen comes in, triggers B cells to make a special antibody called IgE. That IgE then attaches itself to mast cells, basically arming them. The next time that allergen shows up, boom, the mast cells explode with inflammatory chemicals. It's a complex chain reaction, but the cool thing is, we now have drugs that can interrupt it at very specific points. For instance, check this out. What if we targeted that very first step? What if we could just mop up all that IgE before it even gets a chance to arm the mast cells? That is exactly what omalizumab does. It's a monoclonal antibody, a biologic, that literally grabs onto free IgE in the blood, taking it out of commission. Or we could go after a completely different player in this game, the eosinophils. These are some of the key soldiers in the inflammatory army, and they get their marching orders from a signal called interleukin-5, or IL-5. So now we've got drugs like mepolizumab that specifically block that IL-5 signal. No signal, no eosinophil army. It's an incredibly precise way to fight this war. And the toolbox doesn't stop there. We can also block other inflammatory chemicals, like leukotrienes with drugs like montelukast. We can stop them from even being made with Xileuton. Or we can use drugs like cromolyn to stabilize the mast cells themselves, making them less likely to explode in the first place. You see, there are multiple ways to approach the same problem. Okay, let's zoom out a little from asthma and COPD for a minute and talk about some of the more common things we all deal with. Allergies, coughs, and that lovely stuffy nose. For allergies, the go-to is antihistamines. But there's a world of difference between the old ones and the new ones. The first-generation drugs, like diphenhydramine, they work, but they also get into your brain and knock you out. The second-generation drugs, like loratadine, were specifically designed not to do that. You get the allergy relief without the drowsiness. And here's a handy tip. Look at the names. The newer, less sedating ones often end in adine. So what about a cough? For that, an antitussive like dextromethorphan can work wonders by calming down the cough center in your brain. And for congestion, a decongestant like pseudoephedrine tightens up the blood vessels in your nose, which reduces swelling and helps you breathe again. All right, for our last big topic, we're making a shift. We're moving away from the airways and into the blood vessels of the lungs. We're talking about a very different and very serious condition called pulmonary hypertension. So with pulmonary hypertension, the problem is that the muscle inside the walls of the pulmonary arteries starts to constrict, which drives the pressure way up. Think of it like a massive traffic jam inside your lungs. Now, the body normally has this delicate balance of pathways that control whether these vessels are open or closed, and in this disease, that balance is completely thrown off. So, our treatment strategy is all about restoring that balance by hitting 3 different pathways. First, we can block the endothelium pathway, that's the one causing constriction, with a drug like bosentan. Second, we can boost the nitric oxide pathway, which helps open things up, using PDE5 inhibitors like sildenafil. And third, we can enhance the prostacyclin pathway, another one that promotes dilation, with drugs like epiprostenol. It's a 3-pronged attack. So, when you put all of this together, you get the modern respiratory toolkit, just an incredible set of drugs for handling a huge range of conditions. Let's do a quick, high-yield recap. Here's the stuff you absolutely need to know. Beta agonists like albuterol for rescue, corticosteroids like fluticasone to control that long-term inflammation, hyper-targeted biologics like omalizumab, H1 blockers like loratadine for allergies, and PDE5 inhibitors like sildenafil for that very specific case of pulmonary hypertension. This is really the core of it all. The big story here, the real takeaway, is the journey from broad-spectrum drugs to these incredibly precise tools. We've gone from just trying to open the airways to being able to intervene in specific molecular pathways. The level of precision we have today is it's truly amazing. And that kind of leaves us with this final question to think about. As we learn even more about these pathways, are we heading for a future where a one-size-fits-all approach to something like asthma just seems old-fashioned, where every single patient gets a therapy tailored to their specific type of disease? It's something to think about. Thank you so much for joining me for this deep dive and for sticking with us through the whole respiratory module. I'm Dr. Zach from MedHub Research. Don't forget to subscribe, and I'll see you in the next series.